So I think that one of the reasons that I like to walk around is because I reckon that most of the last 20 years, either a member of the administration or here or the government has wanted to shoot me. So I have to keep moving so that I'm a moving target. So we're moving on to the other area of today's proceeding, which is peptide receptor radionuclide therapy. But for me, again, the journey started way back, I record a century ago, when I was at the University of Michigan with the team there, particularly with Jim Sisson and Bram Shapiro. And this was the first neuroendocrine-like disease that I ever saw. For my sins, I had to do some work in the endocrine clinic, and this was one of the first patients I saw who had metastatic pheochromocytoma, and he'd been treated by Bram and Jim with iodine-131 MIBG, which was invented at the University of Michigan, and Neil Petrie, who was one of our chemists there, is here today, and will remember this scan, I'm sure. We now know, well, I now know, this guy almost certainly had a HIF2 mutation because he had polycythemia, which is part of the syndrome. And about that time, and when I came back to Melbourne, I started delivering iodine-131 to children with neuroblastoma and adults with pheochromocytoma. And I was aware of work showing that carcinoid tumours took it up, and I'd been doing some indium work very early on when I came first back to Peter Mac in 1991, and thought, well, maybe this would be better because the work we did with iodine-131 really wasn't very effective. They had uptake, but they never really responded. And when we looked at outcomes, unfortunately, despite a beautiful scan, it didn't really work very well, unlike the theranostic paradigm that we saw with thyroid cancer. The other really important people in this journey for me were Eric Krenning, Larry Kvolz, who was at the Mayo Clinic, and Jean-Claude Royby, who described the somatostatin receptor in malignant tissues. These are now great friends of mine. And serendipity is really a fantastic thing in your life. I went into nuclear medicine with an interest in cardiology and decided that I didn't really want to be a plumber, an electrician or a pump engineer, which is all you can be in cardiology. I was much more interested in understanding how things worked. So I was interested in cardiac imaging of all varieties, cardiac PET and nuclear medicine, echocardiography, MRI in the past. And I had a cardiac stress nurse who was diagnosed with glucagonoma, and Dave Cool had nominated me for the New York Academy of Sciences, and I got their journal, the Annals of the New York Academy of Science, and I read with great interest this report of the very first patient they treated with high administered activity indium-111 octreotide. And they reported really nice biochemical response in this patient, good symptomatic control. And so I wrote Eric a letter. That's what you did in the olden days. You didn't get on Twitter, you didn't do Facebook or email or stuff like that. You wrote a letter, and he very kindly wrote back. And I asked him, would he mind giving me some of this peptide and giving me his protocol, because I wanted to treat my cardiac stress nurse. And that's where it all began. And we treated her. And these are her images. And I was really delighted to see that these lesions that had fantastic uptake in the left lobe of the liver shrank down very nicely. Her symptoms went away. She had a terrible rash on the legs, which is part of the syndrome. It went away almost immediately. And this was really very encouraging. Unfortunately, she had some other lesions in her liver which didn't take up the isotope, and they grew. And I wondered, these must be some other kind of tumour, different kind of tumour. So we biopsied them. We found out they were high-grade neuroendocrine carcinoma. And because I just installed the PET scanner, I thought, well, I should have a look at them. And we did, and they were FDG avid. And so a theme that'll come out in this, and I showed you the slide earlier of that two images, the FDG and the somatostatin receptor imaging. something got imprinted in my brain pretty early, and it was pretty easy to assimilate because I'd grown up looking at perfusion metabolism mismatch in the heart, looking at two different aspects of the biology of the heart. Pretty simple, sort of putting one and one together and making two. And Eric and Dick Queckerboom, and special mention of Dick, who's had a stroke and is unwell at the moment, otherwise I'm sure would have been here. They did the first study with high administered activity, and as we blow out our 20th candles, I really have to pay a great debt of gratitude to both of them, because over the last 20 years they've supplied us with peptide, and they've been an inspiration for our program, a great advice. This is the graph of our peptide receptor program, and it goes in 3 phases. We had the indium era, which I call the cottage industry. It was really tough work because it was expensive. Indium's a very expensive isotope. And we had to admit patients. We only had one therapy room, and we're trying to do iodine work. Sorry, Barbara somewhere there. We were so busy with iodine work, we couldn't fit in neuroendocrine tumours, and they lived a lot longer, and so it was hard work. And there's a little yellow one there, which we were involved in an international trial of the yttrium dotatok or triath there. Then we went into the lutate area, which I call the industrial revolution. You can see it was very popular, went very well. And the last one is where we learned from perhaps the mistakes or the things that didn't work so well in the one-size-fits-all, where we've moved on to a much more personalised era, which I like to think is the Enlightenment. So we used a whole lot of different protocols, and that means that we were thinking on our feet, we were learning from what we experienced. Most of the patients we treated were treated under what we call the SAS, the Special Access Scheme for Compassionate Use. And so the only way we could do that was to treat patients who had failed everything. And so we had patients that had really advanced disease, they'd failed multiple lines of therapy. And most of them, many of them at least, would have been excluded from any of the clinical trials. You know, every clinical trial that a company runs, they try and get rid of the bad ones. They say we don't want anyone with more than double the upper limits of normal of some blood test or another, and they exclude them from analysis. That's our patient population. It's the worst possible group to try and prove that a therapy works in. One of the things that we're very proud of is pioneering the use of radiosensitizing chemotherapy with radionuclide therapy, which we call peptide receptor chemoradionuclide therapy. And it was a pretty simple idea because Peter Mack was at the forefront of combination chemoradiation, of combining radiosensitizing chemotherapy with external beam radiotherapy before that was mainstream practice. And we knew that you could use agents like 5-FU at full dose with full dose radiotherapy because the toxicity was rather low. And because 5-FU was an effective single agent in neuroendocrine tumours, it was a pretty easy argument with the medical oncologist to add it to PRRT. And the basic theory is that the radiation dose response, if it moves to the left, it's a good thing, and 5-FU moves the tumour curve more to the left than it does normal tissues, and that's why it gives radiosensitization. We looked at our outcomes of a group of diverse neuroendocrine tumours, and Grace did this analysis, and we showed a very high response rate on the scans. This is something we'd very seldom seen using PRRT on its own. It was really a great outcome that 43% of the patients had improved, and the remainder were mainly stable who had been progressing prior to this treatment. So indium's really an attractive agent. It's an Auger emitter. It just targets the cell. The problem is that not every cell in a tumour has the receptors on them. And so you're only treating a proportion of the cells. Beta particles are very attractive. Yttrium was the first one that we used as part of the Novartis or Triafair study. The problem with that, it goes about 1 centimetre in tissue, so there's a lot of collateral damage, and there was quite a lot of renal and some bone marrow toxicity in that patient population. But the crossfire effect is really beneficial when you have a heterogeneous tumour. And the really exciting thing was lutetium. And again, The Erasmus group was so seminal in this, the early work with lutetium diquecobum's first paper in JCO in 2005 was really a great stimulus for us. And then I did get on the email, and I sent Eric an email and said, do you think you could give us your protocols and we could start using lutetium? And we did. And the reason we did was because not only was the crossfire attractive, but we did the estimate that we could do this as an outpatient. And so suddenly economies of scale became possible. We could treat many more patients at the same time. And you've seen pictures of our radionuclide therapy, and this was a hooray moment for me, not for the techs, mind you. They weren't quite so happy. Because it was a new protocol, we said, well, we have to add it to the people who failed what we were currently doing. So we took patients who had intense uptake on their trioscan. They had to have uncontrolled symptoms or symptomatic progression. We gave them indium. If they had a good response, we stabled and monitored them. But if they had a poor response, they went on to lutetium with 5-FU. And Daniel Hubble, one of my fellows, did a very nice analysis of the toxicity over a course of treatments. And we found that unlike normal therapies for oncology, where toxicity gets worse with each subsequent cycle, that the worst toxicity was with the first cycle, that they dropped their blood counts, the neutrophils, lymphocytes and platelets a little bit, but with subsequent cycles they improved. And the theory behind that is that you can only kill a stem cell once. The ones that are in immediate vicinity of tumours get a very high radiation and they're killed, and then the rest of the bone marrow is out of range. That the little boy throwing the rocks can only throw them so far that if you're out of range you don't get hit. We also looked at kidney function, which has also been a concern. We showed, in fact, that patients with poor renal function on average improved because some of them had a renal dysfunction. If we improved their liver function, their kidneys got better. But as a whole, there was a very mild reduction. We also found that most of the blood clearance occurred in the first 2 hours. 95% of the activity was gone from the blood within 2 hours. And if it's not in the blood, it's not getting to the kidneys, and you don't need to protect the kidneys. And so we've concatenated our amino acid infusion to 2 hours in patients with normal renal function. That, again, improves the throughput and efficiency and the patient convenience. Have been a practice-changing piece of data. But did it work? We think it did, and again, it takes time to collect these data, and Grace did a great job of looking at this, where we found that the survival in our patients was not reached after a median follow-up of 62 months. It's quite unheard of for this kind of disease. A really fantastic result. People have said to me from the oncology things, well, that's because you're choosing the best players, the people with well-differentiated disease who've got lots of somatostatin receptors. Well, in fact, a third of our patients were in that bad group with FDG-avid disease, who many groups had shown had a very poor prognosis. And almost a half of them had G2 tumours, and mainly high G2 tumours, because we required progression as an eligibility criteria. In fact, 58 of the 68 patients in that original cohort were treated for progression of disease. And we found very high response rates in these patients, however we looked at it, whether we looked at biochemical, molecular imaging or CT. And however they were judged to have responded, it was prognostically significant at a very high level. We showed some pretty spectacular responses in pretty spectacularly awful disease. There's a patient, a 76-year-old guy who's a hepatobiliary surgeon by coincidence, and his liver was just completely packed with tumour, and you can see over a 4-year period his tumours gradually shrinking away. And this is not because he hadn't had other therapies that were tried. This is his chromogranin levels, a biomarker of the disease. Responded initially to somatostatin, was rising, changed to lenalidomide, responded, but only for a short period of time, progressed again, had carboplatin, etoposide, responded, but only for a short time, rebounded, and then we gave him PRRT. And he's still alive in 2016, into his 80s. And he said to, I think, one of our clinicians, I must have had one of those low-grade indolent tumours, mustn't I, to still be alive now from December 2005. In fact, he was a G2 with a Ki67 close to 20%. Not only does it shrink the tumours in some cases, the more important thing in functional neuroendocrine tumours is that the patient's often severely incapacitated. This is a patient who was in intensive care for weeks before we got to see her. She was on a 50% glucose infusion, dexamethasone diazoxide, very poor performance status, nearly dead. And the scan improved, but that's not the story. The patient got out of hospital, normal blood glucose, and David Patterson, who's somewhere in the audience, is writing up our experience in insulinoma. This is not a rare occurrence. This is the norm for this particular disease. We also learned that you can't trust structural imaging. We often get someone ringing up and saying, oh, this patient's progressed after their first cycle of treatment. They've got new lesions and they've grown. Well, the reason they grow sometimes is they undergo what we call liquefactive necrosis and they swell. So this patient was thought to unequivocally have progressed on CT. But there's the before and after gallium scans. You can see the lesion that appeared in the liver was always there. It just couldn't be seen against the fatty liver that was there. And when we turned off the hormone secretion, the fat level in the liver went down and the tumour became apparent. And the liquefactive necrosis in the splenic lesion made it cold. It gave us the answer. Again, emphasising what I said this morning, what's important is the ability to stratify prognosis. And this is looking at somatostatin receptor imaging response. If they have a good response, the survival is excellent. If they don't, it's not so good. One of the other findings that Grace made was that the whole body retention was adversely predictive of outcome. The larger the disease burden, the more likely a patient was not to respond to treatment. And particularly if lesions were more than 4 centimetres, that was an adverse prognostic sign. At that time, we were using a one-size-fits-all administered activity, giving everyone 7.4 gigabecquerels of lutetium octreotate, because that was the protocol that Erasmus had established to be safe and effective in their patients. Well, that's fine with lutetium. Probably doesn't make terribly much difference if you look at the rim of a millimetre or so that a particle from lutetium goes in tissue. For a 1 centimetre deposit, only 10% of the radiation is collateral damage to surrounding cells. In a 5 centimetre, it's less than 2%, very small amount. Yttrium, on the other hand, which had been used by the Basel group in particular, Helmut Mackey's work in that area, you can see that for small lesions, it's a pretty bad equation. More than 60% of the radiation is delivered outside a 1 centimetre lesion. That's not a good therapeutic index. Once you get up above 5 centimetres, less than 25%, it's much better. And the more penetrating beta particles, the higher energy beta particles on Monte Carlo simulations will give much better radiation to these large deposits. And so we introduced a protocol of upfront, when the disease burden was highest and the intensity was highest, a protocol of cycling from yttrium to lutetium, following them down. And again, Grace did a wonderful job following up these patients, and it's just recently been published online, European Journal, showing an overall survival rate in this worst of worst prognoses, the heaviest burden of disease, the largest lesions. Very excellent overall survival with good follow-up and high morphologic and functional imaging response. And I've shown you before that both of those are prognostically impressive. The pictures speak for themselves. This is the Gatade scan before and after in a patient who receives sequential yttrium followed by lutetium. And you can see the marked shrinkage of tumour and just a small liver lesion and a pancreatic lesion in this patient. But they weren't a low-risk patient. This patient had a neuroendocrine carcinoma with a Ki-67 of 50%. And this is the FDG before and after chemotherapy. 3 cycles of one of the most powerful chemotherapy combinations used in neuroendocrine carcinomas, carboplatin etoposide. The patient had unequivocally progressed on that therapy. And you can see the FDG, and remember that's the poor prognostic signal in these. Still a little bit of somatostatin receptor expressing disease, but no FDG-avid disease. Most of the rest of the world thinks that FDG has no role in neuroendocrine tumours. If you look at the National Comprehensive Cancer Network guidelines, they say FDG is not useful for identifying neuroendocrine tumours. They're still operating in the lumpology paradigm. How many lumps do you see? And because most of them are low grade, you don't see them. But you do see the ones that matter. And again, this was a message I learned from that very first patient that we treated, my cardiac stress nurse, but also subsequently over years, even on old technology, I sort of had similar ideas to Michael about segmentation. This is fusion of an indium octreotide scan with an FDG scan without any CT, but using the fusion, you can see that the FDG is filling in the gaps between the somatostatin, and this patient clearly is not a good candidate for peptide receptor radionuclide therapy. And so we've developed this sort of idea of trying to look at imaging phenotype to select patients. And if you look at the likelihood of a patient having a positive somatostatin receptor scan, you can see that it progressively diminishes as grade increases, the green line of somatostatin receptor expression. Conversely, you see FDG avidity, the likelihood of a positive FDG scan increasing. But the interesting thing is that there are some lesions, and Michael's very nicely shown this, that have both. And so the green ones are the ones that everyone is thinking, yeah, I can treat those. I'll treat the somatostatin positive one. I shouldn't treat the ones that are FDG avid. Clearly, the ones that are FDG avid that don't have the somatostatin are unsuitable for PRT because the target simply isn't there. We actually think that the best group to treat, because they have the worst prognosis, the most actively proliferating disease, the most to benefit, and also probably the most sensitive, are the orange. So it's a bit like the traffic lights. The stop sign says, don't proceed, go, don't think about it, just drive through. And the best thing is the amber light. You get through legally, and you don't end up in the red. Hopefully you convert them maybe to the green. And we see that happening. Here's a patient with another G3 neck, a gastronoma, massive disease, widespread, highly FDG-avid disease, marked regression, still some FDG avidity in the primary. This patient had a resection of their disease and remains, as far as we know, disease-free 6 years later. Again, in this FDG-avid group that we looked at, and one of our overseas fellow, Raghav Kashyap, showed very nicely in the group of patients who had highly FDG-avid disease, very high response rate, partial response on CT or stable disease of highly progressive disease. And this is looking 9 months out from treatment, only one patient progressing, and they progressed with exclusively FDG-avid disease. That in retrospect was there, but if we had the computer that Michael wants us to have in the future, he was going to tell us that there was a lesion that was lurking that somehow we missed, that grew and became the dominant clone that eventually led to the demise of the patient. And the adverse signal was very rapidly removed in the majority of the patients. And our progression-free and overall survival data are fantastic in this group compared to if we look at other therapies. And so if we look at approved therapies, everolimus, sunitinib, median progression-free survival in a less advanced, less severe group of patients, 11 months, ours 48 months. One of the arguments about our data is that there was a lack of randomisation. There wasn't a randomised control trial. But neither was the Strasbourg study, which involved a very small 30 patients with pancreatic neuroendocrine tumours treated with CAPTEM, and that's been widely adopted by the medical oncologist in the absence of any real evidence of the sort that they are demanding of PRRT, and look at the progression-free survival in that group. We can also look, although we don't have our own cohort, at the survival of like patients who are treated in environments where PRRT is not used. This is a study from Rennes in France where PRRT was not until recently available. And the right-hand graph, it's somatostatin positive patients who are FDG positive. Progression-free and overall survival in these patients is terrible. Overall survival 19 months. Our overall survival was 55 months. Why don't we get better results? We could get better results. Difference between medicine and magic is magicians know what we're doing. We give one-size-fits-all radionuclide therapy. Someone with a tiny amount of disease or impaired renal function, we give the same amount as we do for a large burden of disease. I think we need better understanding of why patients get toxicity and why they respond in a different way, and dosimetry is the answer. And one of the things that we've been working on, very privileged to have Jean-Mathieu Beauregard as a fellow, very clever physician who's here somewhere, Jean-Mathieu, showed very nicely that there was a very strong correlation between the uptake on a GAT8 scan and an FDG scan, and he worked on a protocol to develop quantitative SPECT, which is now being used by several companies, and Siemens is developing this as a product. By doing serial imaging and correcting for dead time, we're able to quantify the uptake over time, and that's with attenuation correction. That's intrinsic to being able to do dosimetry, and we can now chart the retention of radioactivity, the accumulated activity in tumour and spleen and other tissues and the kidneys. And what Jean-Mathieu found was that the biological half-life of the tracer, or the radionuclide in tumour, was very close to the physical half-life. So the uptake was quite predictive of the radiation dose early. But what was very variable was the biological half-life in the kidneys and spleen, which are the off-target organs for radiation. And that was highly variable between patients. And so we need dosimetry. We can also do that with yttrium because of its small positron decay, and Price Jackson, who's one of our very clever PhD students now, trainee medical physicists, worked out a way of doing the same dosimetry with yttrium. And so we've added this into that protocol I showed you of combining yttrium with lutetium to predict the dose that individual lesions get. In this case, 67 gray, that's for external beam radiotherapy, a curative dose of radiation. But that was the first cycle of treatment. And the kidney is getting less than 5 gray. And over the course with measured dosimetry, in this particular case, we gave well over 200 gray to individual deposits. So what happens when you give 200 gray to tumours? Gee whiz, they respond. They go away on CT, they go away, but not completely. There's still a lesion there that, despite 200 gray, is still living. And that's what we want to understand, is why they don't respond. Of course, all of that's after the event. It's retrospective, it's dose verification, it's not dosimetry. And we know that we can't predict, because of the short half-life of gallium, the retention in the kidneys and the clearance of the kidneys. We can predict what's going to go into the tumour. So we need a radiopharmaceutical that has a long enough half-life, that stays long enough to give us the pictures of the kinetics in the tumour. And we were very fortunate to work with Paul Donnelly's group and supported by Clarity to do a first-in-human study of an agent called copper-64 sartate. The SAR is a nucleating agent that hangs on to copper much better than DOTA or NOTA. The key ring that holds the dangly bit onto a radionuclide was there. And this is in fact the first patient showing the very high retention of the radionuclide in the tumour, the clearance from the kidney progressively over 24 hours. And if we can see it and measure it, we can do predictive dosimetry. And the really exciting thing is that copper-67 is a therapeutic radionuclide that has almost the same physical characteristics in terms of particle energy as lutetium, so the same path length, but a much shorter half-life, 3 days instead of close to 7 days. And so it gives a higher dose rate, should be radiobiologically more effective. And so we're quite excited about moving this sartate into clinical trials. So in conclusion, I think we've come a long way. We've still got a long way to go to understand how to best use radionuclide therapy. There's options for new peptides, new radionuclide combinations, new combination therapies with different radiosensitizing chemotherapy agents are needed. How do we combine this with immunotherapy? And particularly is there a way of optimising administered activity using routine dosimetry, which challenges the convenience of a one-size-fits-all protocol? And I think this will likely improve the therapeutic index further. And so with that, I'll finish.